Now let's turn our attention to another arboviral disease that most people haven't heard of. I didn't mention it when we were looking at mosquitoes, but that was a few months ago, so you may have forgotten about the triple E virus, or the Eastern equine encephalitis virus. It is actually the most severe of arboviral encephalitis and may cause two types of illnesses. There is an incubation period of about a week on average before onset of clinical symptoms. The first type is systemic, with flu-like symptoms, fever, chills, tiredness, muscle and joint aches that can last up to 2 weeks, after which there is complete recovery. The second type is the encephalitic or neuroinvasive form in a small minority of cases where recovery does not occur, but symptoms become more severe and may include irritability and restlessness, vomiting, diarrhea, and anorexia, then drowsiness, cyanosis, convulsions, and ultimately coma. It may become life-threatening for a third of the cases, on average a week after onset of symptoms. Recovered cases with the encephalitic type of infection may have disabling or progressive mental and physical sequelae, ranging from minimal brain dysfunction to severe intellectual impairment, personality disorders, seizures, paralysis, and cranial nerve dysfunction. In many cases with severe sequelae, die within a few years. The triple E virus is transmitted by killer sign mosquitoes, and different types of mosquitoes are involved. With the bird reservoir, Culiceta mosquitoes are the main vector, but because they don't usually bite humans, other mosquitoes such as Aedes and Culex mosquitoes become bridge vectors and transmit the virus to mammals such as humans and horses. Humans and horses are dead-end hosts, and they don't have high enough levels of virus for further transmission to occur. Infections may also be fatal in horses. This disease is most commonly reported in and around freshwater hardwood swamps in the U.S. Atlantic and Gulf Coast states and the Great Lakes region. High-risk groups for the encephalitic type of infection include the elderly and young children. In Ontario, triple E virus positive mosquito pools were detected 10 years ago in 2009 and 2010. So far, we've had one human case. In 2016, 2 infected horses were found in Quebec, and since then the number has increased with 2 in 2017 and 13 in 2018, although we don't know where these animals were located. In 2019 and 2020, more infected horses in Ontario were reported, with 7 in 2019 and 2 in 2020. Just south of us in the United States, there have been more cases, both human and equine. 3 human cases and 57 equine cases have been reported fairly recently, and this was the highest incidence in the last 30 years. Also in the United States, you can see a list of states which are close to the Canadian provinces of Quebec and Ontario, and also the list of cases. In 2007, the first European case of the triple E virus was reported. He was a 35-year-old traveler who was visiting the States and was bitten while on a fishing trip in New Hampshire. I've provided a link with more details on his case. The triple E virus is an alpha virus, so it's in a different family to the West Nile virus, but in the same family as a number of other equine encephalitis viruses. It is also an enveloped single-stranded RNA virus. Serological tests for virus-specific IgM and neutralizing antibodies are used in lab diagnosis. Here is the transmission electron microscopy picture of the triple E virus, which is digitally colored in red and magnified more than 80,000 times in size. There is no vaccine for humans to protect against this disease, and specific antiviral treatment either, so prevention by reducing exposure to mosquitoes is necessary by using insect repellents, wearing protective clothing, and installing and repairing bug screens on windows and doors for exclusion of mosquitoes. Just like for other vector-borne viruses, eliminating mosquito breeding sites in a variety of containers that were already mentioned on previous slides is a good preventative measure. Perhaps we haven't seen the last 2 measures on the list, which are to drill holes in tire swings and also storing kiddie wading pools on their side. St. Louis encephalitis is the last arboviral disease we'll look at that is transmitted in North America. The majority of infections are asymptomatic or mild. After an incubation period of approximately 10 days, a small percentage of cases will experience more severe disease with neurological involvement. There may be neck stiffness, stupor, disorientation, tremors, convulsions, coma, and paralysis. Risk groups for severe disease are seniors and infants. Mortality rates range from 5 to as high as 30%, especially in the elderly. There have been recurrent urban-centered outbreaks in the United States, eastern and central states, and Ontario, with 82 lab-confirmed cases and 5 deaths in 1975. It's a long time ago, but still worth noting that this occurred so that we know that the disease can be transmitted locally. The reservoir hosts are sparrows. Mosquitoes, primarily the Culex species, feed on St. Louis encephalitis virus-infected birds, become infected, and then transmit the virus to humans and animals during the feeding process. SLEV multiplies in both infected birds and mosquitoes, but does not cause illness in the reservoir host or vector. Aside from the common house sparrow, other birds, like pigeons, robins, and even blue jays, can carry the virus, so this disease can be transmitted in urban environments as well as rural ones. Once again, humans and other domesticated mammals are dead-end hosts, and infections can be transmitted from them. The SLE virus is a flavivirus, so it's in the same family as the West Nile virus and other viruses such as yellow fever and the dengue fever virus. Lab diagnosis is the same as for other viruses. Serological testing is used to detect IgM and neutralizing antibodies in serum and cerebrospinal fluid specimens. The picture is a transmission electron microscopy magnification of the virus and is in the original black and white with no digitally added color. Once again, there's no vaccine or treatment for this arboviral disease, so reducing exposure to mosquitoes and their bites is necessary using all the same preventative measures as for the other viruses that we covered in the previous slides. I won't go over the list for eliminating mosquito breeding sites again, as it is the same for the other diseases. We may have enough time to squeeze in yellow fever. While the majority of infections are asymptomatic or experience mild illness, some cases may have flu-like symptoms about 3 to 6 days post-infection. In a small number of cases, there may be a brief remission of hours to a day before jaundice, bleeding, and eventually shock and multi-organ failure occurs. The jaundice is why this disease is called yellow fever. There are 2 main transmission cycles for yellow fever, a jungle or sylvatic cycle and an urban cycle. Risk factors are exposure in forested areas where reservoirs of disease, such as monkeys, are present. An infected human can then return to an urban area where killer sign mosquitoes can bite the infected person and then transmit the virus to another human, thus perpetuating the urban cycle. Yellow fever is endemic and intermittently epidemic in sub-Saharan Africa and tropical South America. Since natural immunity accumulates with age, infants or children are at the highest risk of disease. Even though we don't have local transmission of this disease, as we don't have monkeys in Canada, except in zoos, where the monkeys have been screened rigorously for these types of diseases. Yellow fever is a nationally notifiable disease, and there have been 11 cases reported in the last 10 years. Serological detection of virus-specific IgM and IgG are used for lab diagnosis, and yellow fever vaccination history is required to rule out false positives. Cross-reactivity with other flaviviruses may also occur, once again leading to false positives. Reverse transcriptase PCR may be used for more nucleic acid testing, but this needs to be carried out early in the illness, in the first 3 to 4 days, otherwise false negative results may be obtained. The yellow fever virus is a flavivirus, so it's in the same family as West Nile and the St. Louis encephalitis viruses. The electron microscopy picture shows large numbers of viruses magnified by more than 200,000 times. Unlike all the other arboviruses we've covered in this lecture, there is a vaccine for yellow fever. It is a live attenuated virus and offers protection for 10 years. It is recommended for travel to at-risk areas in South America and Africa, but for certain countries it is a required vaccine and you cannot travel there without immunization papers. There is no treatment for yellow fever, and severe cases need to be given supportive care and closely observed in the hospital. Aspirin and non-steroidal anti-inflammatory drugs should not be taken because of the increased risk of bleeding, and the best analgesic is acetaminophenol or Tylenol. It is also essential for cases to stay indoors under mosquito nets during the early part of their illness to prevent mosquitoes from biting and transmitting the infection to others. This is the first arboviral disease where humans are not dead-end hosts. Although preventing mosquito bites and reducing exposure to mosquitoes is the same for the other diseases, it is important to know that peak mosquito biting times for Aedes aegypti, the vector for yellow fever, is not at dawn or dusk. This is a day-biting mosquito, so it is important to be protected throughout the day as well as during evenings and early mornings. It's also recommended to stay in cool, air-conditioned rooms which have intact bug screens to reduce the risk of mosquito bites.